Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
Hey guys, Jeff Graham back with you. I'm the Chief Medical Officer of Wild Health, and I am thrilled to be on the podcast today with someone who been acquainted with for a little bit, but really have become more acquainted with recently through traveling to similar conferences and just reigniting a partnership that we've had and for a while, but really are digging back into right now because we're going to talk about something that is maybe one of the most important levers we can pull in the field of longevity optimization. That is sleep. I think there's no one better out there to talk to us about this today than Dr. Sahil Chopra. He runs Empower Sleep. It's one of the partners that we have long valued and are now kind of reigniting, I'd say, a relationship with since you guys have some new offerings. So today we're really going to dive into the science of sleep and why it's such an important metric for us to be tracking and something to be treating like we do exercise, diet, all these other hacks we go after. And it's sitting right there in front of us, right? So, Sahil, take it away. Tell us a little bit about yourself.
Oh man, thank you, Jeff. Thank you so much for having me back today. Talking about sleep is something I dearly enjoy. From a background standpoint, I have pretty humble beginnings. I'm an internist, did residency at UCLA, trained as a pulmonary and critical care physician at Loma Linda. I love working in the ICU. It's so funny, when I was in residency or in fellowship, I had recorded the sound of the ventilator, that dun 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 dun
Yeah.
dun 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 dun, dun, and that was my ringtone. Like, that's how much I
That's the next level, man.
yeah, I was one of those guys. I was one of those folks that would run to the codes uh overhead whenever, I was
It
one of
wasn't
those
even your
residents.
job.
And
It was someone
totally,
else's. Yeah.
totally. And I love I still love working in the ICU, but then I became deeply interested in sleep medicine. There's an overlap between sleep medicine and pulmonary medicine because of a condition called obstructive sleep apnea, and ended up doing a sleep medicine fellowship, wanting to learn more. Luckily matched at Harvard, and have been doing primarily sleep medicine ever since.
That's awesome, man. That's awesome. And a little bit of background on Empower. When did you decide that it was going to be, a part of your legacy to found a company that really is based around optimizing our sleep?
Yeah, it's interesting that you think of it that way. Like, that wasn't the idea in the beginning. When I
Okay.
finished fellowship, we were, Ivy League institutions operate very differently than what community-based programs do.
Yeah.
And when I was doing my fellowship at Harvard, the idea was your job as a sleep doctor is not to be a sleep apnea doctor, but rather to be someone who understands someone's physiology when they are sleeping.
Hmm.
And when you look at it that way, you can, like, not only identify pathology like disease, but you can start to look at sleep as this window into someone's health. You can look at sleep from the lens of, how do I make it better and more optimized? And when I finished fellowship, all the places that I even had a conversation was like, you're going to be like a sleep apnea doctor.
Hmm.
And I just felt like, man, what a waste of learning uh, from 1 year of fellowship. So then I decided to open up my own sort of program. And it started off as like an online sleep medicine clinic with this idea of providing Harvard grade sleep care online. And that is what evolved into Empower Sleep. So it wasn't even like this digital telehealth thing that I want to start. It was like, I just want to do how I was trained to do sleep medicine.
Yeah.
And over time and multiple iterations, it's turned into like a completely different thing.
Yeah.
But the DNA is still the same.
Yeah, for sure. So I think that's super. I think that speaks highly to obviously your company, but your own character, because what you didn't come at it with this real entrepreneurial spirit. Hey, I want to start something that does really well and makes some money and gets me out of the ICU because I love it so much. You came at it from this angle of I've got all this amazing knowledge base and I'm wasting it right now unless I'm able to do something on the side.
100%, man.
Yeah.
That's exactly spot on.
Yeah.
And
Great.
then when you start doing it that way and you see things, like it would be really hard for you not to do what you do anymore,
Yeah.
because you have seen it. And it's like,
Yeah.
no, I cannot work at Kaiser anymore
Yeah.
and in their ER or whatever, wherever you might be just a body doing
Yeah.
or a cog in a system. And once you get the opportunity to help somebody optimize and mitigate pathology in the way that you're doing from a whole health standpoint,
Yeah.
the way that we're doing from a sleep standpoint, it just becomes impossible to go back.
Yeah. That really resonates with me. I had someone ask me the other day, well, if this precision medicine thing, if it didn't work out for you, you could always just go back and, you've got good job security anywhere. And it's like you said, once you've seen, you can't unsee. It's like I can't go back to doing that anymore. I know there's so much more to the story, and that's how we try and approach everybody's health. So that's fantastic. Um, all right, I got a banger I came up with looking at our kind of pre-script. I was like, let's go off script. Let's have some fun. So thinking about, so I was fortunate enough to watch Sahil give a presentation and sit on a panel around the benefits of sleep. Was I just last weekend at the Buck Institute, or I guess 2 weekends ago, out in San Francisco. Amazing conference. It was great, right?
It
Yeah,
was phenomenal. Eric Verdin, who puts on this conference and is the CEO of the Buck Institute, um, is just a rock star
yeah,
person. Uh, and if for those of you who are listening, the Buck Institute is like a museum or a science institute for longevity. You can ask them to take a tour, and they'll take you down, and they have like I think 30,000 mice in the basement that they have for research purposes. It's built on this 400-acre
yeah. It's
donated
beautiful.
piece of land with cows grazing around, and this like beautiful building, and it's definitely uh, a place worth visiting, I would say.
Yeah, I agree. I had heard that, but it didn't strike me until I was there. You're driving through this beautiful farmland and pull up to this place that could just as well be sitting in, Paris or Manhattan, as an art museum or something. It's just beautifully built. And yeah, truly a tribute to what we're trying to practice in our own lives. So it was a lot of fun. So tell me, start things off here. We got a lot of detail we can get into around the science of sleep, but I thought a good place to start would be if sleep were a drug, what would the FDA label say about missed doses?
Mm, that's a good question. I think like the obvious thing is, if you underdose on it, there would be a black box warning
Yeah,
that if you underdose on sleep and you don't consume enough of it, there would be a black box warning for sure, because we know from large amounts of evidence that people who do not sleep well or consistently have short sleep duration or who have significant night to night sleep timing variability, like from a circadian rhythm standpoint, like their sleep is, they have like this idea of social jet lag happening on a daily basis.
yeah,
Their mortality is substantially higher. And if you ask the question, like, why is that the case? What we learn is there is a higher prevalence of coronary artery disease, hypertension, cognitive decline in the form of dementia, anxiety, depression, metabolic syndrome. So, all of these chronic conditions that you are trying to prevent in this precision medicine program, all of those things are substantially higher. It's not causation, it's association,
mm,
but that will come, I think, over time.
hmm,
But if for people who are underdosed on sleep, Like all of those things are substantially, the odds ratio and relative risk is substantially higher if someone doesn't sleep well or
Yeah.
his sleep is shorter.
Yeah, so take us down that path a little bit. When you mentioned, I mean, like 6 or 7 of the most common conditions that affect our population, and even in precision medicine where, we have a lot of people coming in, doing all the biohacking they can, taking ridiculous amount of supplements and, doing all the looking into peptides and, thinking about which, weighing their food every day, really monitoring their caloric intake, dialing into different types of exercise. When you think of the things that kind of break down first with when people are sleep deprived, is there an order that you can put those things in? Do you see it in your own practice with people? Is it cognition? Is it mood? Is it metabolic things that start to happen?
The way that I would think of this, or at least invite the audience to think of this, is I would categorize acute sleep deprivation and chronic sleep deprivation in two separate buckets.
Okay.
Okay, because like acute sleep deprivation, like you and I have both experienced it in residency and fellowship and the
Yeah.
kind of work that we did at the hospital. Um, Acute sleep deprivation is causally associated. It is causally it causes mood fluctuations, lower tolerance for stress, emotional instability, uh, cortisol dysregulation, higher blood pressure, more dysmetabolism of blood sugar, even with like one night of dysregulated sleep. Right? That is like we know that happens in the acute setting,
Yeah.
and then chronically is all of the things that you've mentioned, and in what order they come in probably depends on the disorder that one has. So, like how one's physiology behaves in because of chronic insomnia is going to be very different as compared to someone who has sleep apnea. And even within those conditions, there is a spectrum of severity. So if someone has severe obstructive sleep apnea with 60, 70, 80 events per hour, that person is at a much higher risk of having a stroke or a heart attack or atrial fibrillation than someone who has mild sleep apnea uh, and very severe insomnia. Someone who has severe insomnia might be at a higher risk of having like cognitive decline and Alzheimer's disease. So it's very hard to answer these questions in
Yeah.
order, but if we bucket them into what does acute sleep loss result in from a physiology and performance standpoint, and what does chronic sleep loss result in, I think it becomes a little bit easier to understand. And one, m- I'm forgetting the name of the other um, panelist that was with us. He said this really profound thing that sleep is the first thing that we take away from, uh,
Yeah.
and
Yeah.
I thought that was like really like powerful. That is the first place where we take out from when we're trying to compensate for something,
Yeah.
and many times we don't even know that we're doing that, and we are not aware that our performance or cognition or thoughts are impaired because I have less sleep until you regain it back.
Yeah. Yeah, for sure. I've experienced that myself, and I think as I've aged, it's definitely become more noticeable.
Oh, for sure.
Just the
Me
night
too.
or 2. Yeah, it's crazy. So let's take a step back then, and maybe we should have laid some groundwork with kind of defining these terms. You, of course, mentioned sleep apnea, which is a thing I think people hear more than anything about, and we can get into that and some of the details about what actually defines a diagnosis of that. But let's talk about insomnia first, because I think that is the thing that I hear, at least, most Americans, a great majority, 40, 50% almost, if not more, suffer from. What does that mean? Is there a clinical definition of that? And also this kind of myth of the super sleeper. I'd like to hear what your comments are on that too. Yeah.
Yeah. So insomnia is broken into acute or chronic.
Hmm.
Acute insomnia, an example would be like a cancer scare or a death in the family or a breakup or something that causes either difficulty with sleep onset or sleep maintenance and is resulting in some degree of daytime dysfunction. and it lasts less than 3 months.
Less than
Okay,
3 months. Okay.
less than 3 months. Um, Chronic insomnia, however, is a completely different beast. It usually starts off as acute insomnia, where over time people develop these like maladaptive behaviors, like these thoughts, these emotions, this dysregulation, this conditioned arousal that, oh, I'm not a good sleeper. I need to catch up on sleep. So these are maladaptive behaviors that people accumulate unknowingly, trying to compensate for this acute insomnia and dysfunction that they had, which eventually turns into chronic insomnia. And chronic insomnia, defined by similar in the sense that it's longer than 3 months. You have daytime dysfunction, and you have difficulty with either sleep onset or sleep maintenance.
Okay. Yeah. Sleep onset, just to define again, like we think about what's normal for that. What is a normal sleep onset?
Most people should be able to fall asleep within 30 minutes if of when they give themselves this opportunity to sleep. Like if I'm sitting in bed, uh, watching television, not trying to fall asleep, I wouldn't consider that insomnia.
Yeah.
I would, insomnia would be that I've turned off my lights, I'm psychologically ready to go to bed, but now I'm not able to do so, or I have a difficulty with staying asleep, and I have these frequent, prolonged nighttime awakenings that are then causing dysfunction during the day. Then I would consider that to be a problem.
Okay. And is there a time period cutoff, or is this more subjective for people?
It's very subjective. The definition of insomnia is subjective. The only objective part of this is the time duration. Like how long has this problem been going on?
Okay. Okay. Got it.
Like a sleep study, it does not really. You can't like we cannot diagnose sleep. We cannot diagnose insomnia on a sleep study. We can see it, but we don't really diagnose it that way.
Yeah. Yeah. Okay. All right. And then thinking about kind of shifting gears to the other big one that we hear about a lot, again, sleep apnea. How common is undiagnosed disordered breathing and sleep? And especially thinking about like our high performers who, a lot of times wear this sleep deprivation like a badge, like, oh, I don't need to sleep. I've got all this on my plate. I've got to work through it. How often do you see that? How common is it in the population that you find undiagnosed sleep breathing disorders?
Sleep apnea affects anywhere between 5 to 10% of the population, depending on the age, and that prevalence goes up as we get older. Okay. Like in the younger population, it's probably 5%. In the Medicare population, it's probably closer to 10%, maybe even higher. The prevalence is more in men versus women, except when women transition from a reproductive age to a non-reproductive age. So post menopause, men and women kind of equalize in terms of the prevalence of sleep apnea.
Okay.
Um, the other question that you asked around folks being undiagnosed, the literature at least currently reports, and it might be less now, but the literature says that 80% of sleep apnea is undiagnosed,
Wow.
and which is high, which is like pretty high. Like if I said if there is a condition like diabetes or hypertension with like a 10% prevalence, and if 80% of it was undiagnosed, that would be pretty, like nobody would really believe you.
Yeah. Yeah.
But that's actually true for obstructive sleep apnea, that 80% of sleep apnea, maybe a little bit less, is still undiagnosed in the population.
Okay. Meaning that upper level of like 10% of people actually carry the diagnosis is probably way underrepresentative. Okay.
Exactly. Yep.
Okay. Wow. Yeah. So, thinking about some of the stuff people are using these days. So I had the opportunity to go through your program and it was fantastic. Wore my sleep ring for a couple weeks, learned a lot about myself and the fact that I actually do have some very mild apnea on certain nights. And it tended to, what I thought was genius is it was, it was able to tell me when I was moving more, when I was laying on my back more often than my side, which I think is a big player. Um, but I was looking at that compared to like my Whoop and my Aura Ring, which are becoming so popular. And I know you probably hear this all the time. And I was really thrilled to hear you guys address this at the conference. What do those things actually tell us that is specific to sleep?
The the way that I would like frame it is, think of a sleep study as an in-body scan and a wearable like a scale.
Okay.
Like a scale tells you your weight, um, but an in-body will tell you like all of this stuff about body composition.
Hmm.
And similarly, a sleep study will tell you what is happening to your physiology minute by minute when you sleep. It'll tell you, do you have apnea or not? If so, what stages of sleep is it happening in? Is it in REM sleep or non-REM sleep? Is it on your side? Is it on your back? Um, it'll tell you about movement. How much do you move? And is that movement because of sleep apnea or not? It'll tell you about sleep fragmentation. And if that fragmentation is happening, where is it happening during the night? If you're having if you're having heart rate spikes, what could be causing it? So a sleep study, sorry, is a way of really understanding someone's central and autonomic nervous system and movement during this window of sleep, um, where the data is sampled 1 time per second versus data being sampled from a ring like once every couple of minutes. So it's a very high resolution way. It's kind of like the other metaphor that I use sometimes is it's an X-ray versus a high resolution CT scan.
Yeah.
Like an X-ray is good, it'll give you some information. It's a great place to start. But if you see something, you're like, oh, I'm not sure what that is. Then the next thing to do is going to be a CT, CAT scan to understand what's going on and where is it, what lobe is it in, how is it next? Is it close to a blood vessel or is it far from a blood vessel? So it just gives a lot more information from from a clinical standpoint.
Yeah. 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 So on that note, like getting into this physiology of sleep and what you guys can see, second to second, what are some of the things that come to mind when you talked about, this idea of being a physician that is actually, trained well in sleep physiology, how we should look when we sleep? Can you go over some of those just normative numbers that you talk about? What should match up when we're sleeping, respiratory rate, heart rate, etc.?
Yeah. I'll start off with the basics.
Yeah.
And, the way that should look at sleep is through the lens of timing, duration, uh, and quality. So, what is the timing of sleep that someone is sleeping? Is one sleeping during their body's nighttime? That's the
No.
question that we need to ask ourselves. Like, if I'm a shift worker and my body's nighttime is between 10 to 6, but I'm actually working at that time and I'm consuming then sleep during the daytime, that's a complete misalignment of when I'm sleeping and when my body thinks it's nighttime.
Mm.
So, timing of sleep is critical, that we should consume sleep during what's called the biologic night. That's step number one. That's like one of the most important things. The second thing is on duration. The duration of sleep, it changes as we age, but for most adults, it's somewhere between 7 to 9 hours. Like we want to give ourselves 7 to 9 hours of sleep opportunity, and we should be sleeping at least 80 to 90% of that time. So sleep efficiency should be like 85% and above. And then as you look into sleep architecture, um, what is healthy sleep architecture? And
Mm.
about 20 to 25% should be REM sleep, 20 to 25% should be deep sleep, and about 50% should be light sleep. And it's not that light sleep is bad. Like I have so many patients that say, "Hey, I want to have more deep sleep." It's like, no, you already have relatively what evolution has designed this to have from a healthy sleep standpoint. You're already there. I don't know if I give you more REM sleep or if I give you more deep sleep, if that's going to be good for you or not. I think these are all like really interesting questions, but having, about 50% deep, 25%, uh, 50% light, 25% deep, and 25% REM is like a healthy distribution of sleep um, for adults. And as we get older, the amount of deep sleep that we have kind of goes down, and the amount of light sleep that we have kind of goes up, and the amount of time that we awake in the middle of the night goes up as we age as well. So when we talk about this idea of like what is healthy sleep, it's giving yourself opportunity to sleep during the biologic night. So timing needs to be as optimal as possible. We don't want it to deviate more than 1 hour on each end on a nightly basis. We want us to give people 7 to 9 hours of sleep opportunity, and we want the architecture to be as close to physiologic as possible, where there's healthy distribution of the different sleep stages in the appropriate cycles across the night. And you want to make sure that it is free of pathology.
Mm.
And you want to make sure that it is you're relatively idle during sleep. You have appropriate heart rate dipping during sleep. Your breathing is healthy. You are not snoring, and you don't have obstructive sleep apnea during sleep, and you don't have a lot of motion during sleep.
Yeah, so that was something that I noticed with my own sleep study that I learned is that there were some times where my breath rate, my breathing rate, and my heart rate were a little bit mismatched. So that's something. Is that kind of what you're referring to, or there's this time? These are kind of almost missed opportunities where you could be in this when those are more synchronized, where we're getting better sleep.
Yeah, it depends. During REM sleep, for example, there is a level of dysynchrony that happens. During REM, REM is kind of like a sympathetic predominant state during this window of sleep. And so heart rate variability is much more, heart rate is much more variable. Respiratory rate is also much more variable. And, uh, but if someone does not have apnea or any crazy movements during that time, then that would be considered normal. So, um, I think it just kind of depends on what's the exact context.
Yeah,
But generally speaking, during stages of deep sleep, there is much more synchronization of breathing and respiration. During wake and REM, there is much less synchronization of breathing and the beat to beat, the heart rate.
yeah. I mean, REM sleep. Correct me if I'm wrong here, but the brain doesn't know we're asleep, right? It's in a very active state. It's when we're
Yeah,
dreaming. It's when we're storing memories, storing long-term knowledge that we're trying to kind of organize in the right files. Is that correct?
100%. Like
Yeah.
from an autonomic nervous system standpoint, REM and wake look almost the same.
Hmm.
The only thing is that the body is paralyzed and you should not be moving.
Yeah.
And in fact, if someone is moving and acting out their dreams, that's like a pathologic state.
Yeah.
I think you and I had talked about this. There's a condition called REM sleep behavior disorder,
Yeah.
and if people have that, it could be a precursor to Parkinson's disease
Yeah.
because the cortex tells the body not to move during REM sleep, and if there is dysregulation of that or the lack of inhibition of movement, that is a sign that the brain is degenerating faster than it should.
Yeah.
And sometimes that can manifest in sleep.
Wow. Yeah. So it can actually be some insight into a risk for Parkinson's, which is something we have patients talk to us a lot about. So another reason to think about a sleep study for sure. Make sure that's not happening to you. Though most of the patients I've had who've had that, their partner or one of their family members knows if they're acting out their dreams. That's usually
Yeah.
pretty apparent, right?
It's usually very obvious, from like the bed partner will mention that my husband or spouse, like sometimes they'll like scream in their night or have a very vivid dream and they may have,
Punching the air or something. Yeah.
yeah, the
Yeah.
bed sheets are all over the place or something
Yeah.
along those lines.
Yeah. Yeah. So what is one metric kind of staying with this theme of looking at the things that we get in our consumer wearables? We get HRV, which is something people are really focused on. And I wonder that's one metric I wanted to ask you about personally, but are there other metrics that people get from these wearables that we all have on our wrists or chests or fingers these days that you mostly ignore? You think, yeah, it's really not that important or accurate, really not coming in.
I actually put a decent amount of weight on the trends of the data that comes out of the wearables.
Mm-hmm.
Like I have a Garmin. I've tried all of the other ones, and I look at my Garmin score every morning. And like generally, directionally, there is like some degree of correlation. And depending on how these scores have been defined, some of them are black box. Like this idea of a readiness score is relatively black box. There's not a lot of information on how this was computed. Apple, on the other hand, has made their sleep score completely sort of open. And, you know, I think they give us some directional insight into how good of a job are we doing at giving ourselves enough of an opportunity for healthy sleep. And so I do look at it. I would not use it to track pathology. I think, this is a interesting, I just want to make a distinction that
Yeah.
is worth noting. Um, Wearables are very powerful tools when you have someone in the bucket of, I have healthy sleep with occasional disruption.
Mm. Mm-hmm.
That's most people. They have healthy sleep, but then there are these intermittent disruptors, travel, kids, work, something along those lines.
Yeah.
But then in a separate bucket are people who have pathologic sleep because of a disorder,
Mm-hmm.
right? And if someone has pathologic sleep because of a disorder, in that situation, I would completely discount what their wearable says from a longitudinal tracking standpoint, and I
Okay.
would use the medical grade device.
Okay.
But if you're someone like me or you who generally have healthy sleep with occasional sleep disruption, then like these wearable devices do a pretty good job at directionally telling us, are we going in the right direction or not? But we don't know if we're in the other bucket until we do a sleep study.
Yeah. Yeah.
So that's why I think everyone should have a sleep study at some point in time. But after you have the sleep study, and if you are free of pathology, then tracking your sleep with a consumer grade wearable is a very wise thing to do.
Okay. Okay. That's well said. I think that really helps for our audience to define. And I agree with you 100%, which is why we're making this an offering with all of our premium memberships that, Empower Sleep is something you must do. You got to get it done, or a sleep study of some sort. I just like your company. So, um, yeah, man. So, we've talked a lot about insomnia and some about sleep apnea and the underdiagnosed, likely prevalence of it. Anything else that you'd want to say? I think one thing a lot of people are scared off about is that first step of getting a sleep study because they may find out they have sleep apnea and they get scared. They see these Darth Vader type masks that have been associated with it for so long. Can you, clarify that a little bit? What are current treatment options? Is it getting easier to treat?
100%. Thank you for this. It's very important that you bring this up.
Yeah.
20 years ago, if somebody got diagnosed with diabetes, they kind of bought themselves insulin.
Yeah.
But that's not the case anymore, right? Because you
Yeah.
have these continuous glucose monitors, and lifestyle and medications and supplements can be a game changer for someone. Similarly, that is also true for people who have obstructive and central sleep apnea, where if someone has mild intermittent disease that is confirmed with multi-night testing, then you figure out what is causing that intermittent disease and you abstain from it. Or there are other like behavioral things that can be done with tongue exercises, better, healthier nasal breathing. Um,
I learned
now,
like literally like playing the didgeridoo can help.
100%. Yeah, didgeridoo. You won't. I had a patient, a very famous singer, who, if you look at his picture, you're like, oh, this person has obstructive sleep apnea. And you won't. And when I read his sleep study, I was just like blown away by how healthy his breathing was because of sleep, because of singing. His How healthy his breathing was because of his singing and his upper airway being as strong as it is. So the idea of a didgeridoo, the idea of an instrument, all of these things are a byproduct of doing that is our muscles of the upper airway become stronger.
Yeah.
And as a result of that, the prevalence of sleep apnea is likely lower.
That's so interesting.
And
Yeah.
and it was like I was fascinated. I was like, "This is crazy. I haven't seen that." I went down this like open evidence search, and there you go.
Yeah.
Um, so like the idea of didgeridoo, playing instruments, the idea is if you have a stronger upper airway musculature,
Mhm.
then there is lower predisposition for collapse in different stages of sleep, and it is protective against having sleep apnea. So one way to replicate that is through this uh, concept called myofunctional therapy, where one is basically doing physical therapy for the tongue.
Mm.
And if the tongue is a stronger muscles and the upper airway is a stronger place, then the prevalence of sleep apnea is lower. And then, you have nasal strips, internal and external, that can help stent open the airway. So I feel like there's a lot of different solutions available. Um, and now there's even medications that are coming out. Depending on the burden of apnea and the quality of sleep, they will be successful. So I think it is completely a myth that the only solution for sleep apnea is a CPAP machine.
Yeah. I'm so glad we stumbled into that because I think our audience needs to hear that. I hope people can understand that better, especially this physical therapy thing. And then likewise, I think this still stands true for insomnia. We're not just talking about a prescription medicine you're on forever. Cognitive behavioral for insomnia, I think, is super powerful, right? I know you guys actually offer that and are big fans of that.
Yeah, it's amazingly powerful, especially if someone has sleep maintenance issues or sleep onset issues or has like a underlying driver that's causing that symptomatology of insomnia. And I've taken off numerous people from these sedatives and hypnotics that creates sedation but not necessarily sleep. And I want to make that distinction.
Yeah, they have increased risk of different things, right? I mean, the acute period, you're more likely to have a fall and likely develop Alzheimer's or something like that, and some sort of cognitive decline in the long period.
Yeah, 100% that. And then, one of the processes of sleep in the brain is there's a system in the brain called the glymphatic system
Mm,
that
mhm.
filters beta amyloid and toxins during sleep. And what we've recently learned, there's a recent really nice paper uh, looking at the function of the glymphatic system in people who are taking uh, zolpidem versus not taking zolpidem. And
Wow.
what they discovered was the process of the glymphatic system is impaired in people who are taking zolpidem. So, like, what that basically ends up telling us, at least what I inferred from that, is people who are taking sedatives and hypnotics, although they might be sleeping or they think they're sleeping, but that sleep is not physiologic in the brain. And it might not necessarily, they might be at a higher risk of developing Alzheimer's and all of these cognitive decline issues across time.
Yeah, for sure. One more thing I made a note to myself I wanted to ask you about because I get asked about this all the time. Mouth breathing. Mouth taping. Have so many patients that do that. I want to think I know the answer to this, but I want to hear your thoughts on what risks that maybe puts you at, what you see in someone's sleep study if they're mouth breathers.
So, mouth breathing during wakefulness versus mouth breathing during sleep. I think it's, we'll
Yeah,
just make a
okay.
distinction there. Um, mouth nasal breathing is a more physiologic way to breathe. I think that's like that is the way that humans should be breathing most of the time. And there's a really good book for the audience that was just extremely formative and enjoyable by James Nestor
By
called
James Nest Breath.
Yeah,
Yeah. Yeah, a
yeah.
lot of our folks have read that. We recommend that. Yeah, yeah,
And it was like, and I'm a pulmonologist, right? So when I was reading, I was like, yeah, dude, this is like spot on. This makes so much sense. And
yeah.
like, I wish, how come no one ever told me this in medical school? Like I was having these like epiphanies as I was reading it, so he talks a lot about this,
Well, and he
and
literally had those plugs implanted in the back of his nasal pad, so he was
yeah,
forced to mouth breathe for, like, what, 6 weeks or something?
yeah,
Yeah.
totally. You block your nose, you are guaranteed to have obstructive sleep apnea until proven otherwise, assuming you don't have a blocked nasal passage in the beginning, right?
Yeah.
Over time, one can make the argument that there will be some adaptation and compensation that will happen, but generally speaking, nasal breathing is the way to breathe. From a nitric oxide standpoint, from an oral hygiene standpoint, from a dentition standpoint, like we're not supposed to we're not supposed to be living with dry mouths,
Yeah.
right? So that's daytime breathing. And then nighttime nasal breathing versus mouth breathing. If someone has obstructive sleep apnea that is mild, we have the evidence to demonstrate this because we do this like multi-night testing. So I can do these experiments of how is your breathing like with mouth tape and without mouth tape. And what we generally observe is people who have mild apnea or moderate apnea, their breathing and apnea burden is typically lower with mouth taping. I have had a few people who, when they use mouth tape, who had severe apnea, their sleep apnea burden was higher. So
Mm.
I think it's a little bit nuanced to give like a generalized answer. But if someone does not have sleep apnea, mouth taping will probably help them improve parasympathetic tone and just healthier breathing, period. But if someone has substantial apnea or snores loudly and there's witness pauses in breathing, I would use mouth tape with a lot more caution and some level of monitoring.
Okay. Yeah.
And
I like.
there is like enough evidence for people on just on PubMed in meta analyses that suggest that mouth taping could be beneficial for people who have mild degrees of obstructive sleep apnea as well. So I'm very pro mouth taping. I shouldn't say pro mouth taping. I'm pro mouth closure, and you choose like how you want to do that. Tape is just one mechanism of doing it.
Yeah. 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 Um, yeah, and I love the emphasis you put on the importance of nasal breathing. You know, when we breathe through our nose, we warm the air better before it gets to our lungs. We have all these hairs that are supposed to do that. I mean, James Nestor covers it beautifully in his book and what all he went through when he did plug his nasal airways for good. And covers a lot of those studies and that evidence well. Um, all right, man. Well, I want to be respectful of your time, but I got a couple more kind of closing questions. When for one of our folks and you know who maybe has not had a sleep study, and we're going to try and convince them to do that so we can figure out what's going on with their sleep. Um, what is a way to tell? Are there simple subjective measures that someone can use at home to to know that their sleep is getting better? You know, regardless of tracking, is it as simple as saying I feel more rested when I get up in the morning?
Yeah, no, 100%. I think there's like in my head, there's four. Do I fall asleep easily? Do I stay asleep throughout the night? Like, is my sleep relatively consolidated? One or two brief nighttime awakenings is very normal depending on the age. But
Yeah.
um, so can I fall asleep easily? Is my sleep relatively consolidated? Do I wake up rested? And is my energy level during the day where I want it to be? And if someone answers like in a positive way for any of these four directions, like that's a very easy subjective way of knowing that my sleep health is trending in the right direction.
Okay. I'm gonna put you on the spot with this other one because I know the answer is probably gonna be it depends, which is our answer for a lot of things at Wild Health, looking at genetics and epigenetics and everything. But is there people are always interested in supplements. And I'm wondering if you know of any literature, you know, that is just like, yes, across the population, this is safe. This usually improves sleep. Do you have any recommendations there?
No, I don't. Like
Yeah.
being completely the way that you framed it, like it's really hard to there is no supplement that I am aware of that uniformly will improve someone's sleep. Um yeah, yeah, I'll just stop there.
Okay. All right. Say that's a safe answer, man. It's a good place to stop. Yeah. You're just gonna get yourself in trouble if you go on, man. Yeah. Yeah. Um, All right, man. Well,
Yeah.
any other questions that you wished more physicians or health coaches would ask about sleep? That's one thing I wanted to ask. What might I be missing in talking to my patients about sleep that you guys now those 4 questions you just hit, I think are definitely takeaways for sure. But yeah, is there anything else that you wish providers were more forward on asking folks, to really prioritize this topic?
I think I would invite folks to start thinking about sleep a little bit differently, um, from the sense of doing as a part of a preventative checkup. After we hit a certain age, I strongly believe that people should get a sleep assessment done. That
Yeah.
is beyond the idea of how do you feel when you wake up. Because I think many times someone who is chronically not sleeping so well or has some level of sleep reserve, they may not know that they're not sleeping well, even though they may answer all of these questions in a relatively positive way.
Yeah.
And I think when one answers those questions in a negative way, then it's like, okay, there's probably a sleep disorder going on. And like where you're coming from and where I'm coming from is from the preventative mindset
Yeah.
of like, how do I risk stratify someone 5 years in advance who has sleep that is older than where I want it to be for them. Like
Mm.
they're a 40-year-old, but they have the sleep of a 50-year-old.
Mm.
And how do what, like, I would not know that if I never tested and looked at their sleep.
Yeah. It's the
So
same way we think about coronary artery disease, right?
100%.
Like, yeah.
Mhm.
Okay.
Exactly. And I'm inviting folks and physicians to look at sleep that way. That as a part of an annual checkup after you hit a certain age, and that number might be, I don't know what it is. We need like population-based, studies to figure that out. But my intuition is it's going to be somewhere between 40 to 50.
Yeah.
That, somewhere between that age group, you get a sleep study, a home-based sleep study to understand what is the health of your sleep. And then you track it every couple of years across time to see how that changes. And that's not happening. I mean, you guys are going to incorporate that over time as the program evolves. And I've been inviting physicians to look at sleep that way because sleep is a window into someone's health. And
Yeah.
if we can identify pathology sooner, and we can see that their sleep is declining, we might be able to intervene sooner to risk stratify and prevent downstream disease.
Yeah. And that's beautifully said, man. I think that's a good stopping point. So Sahil, I really appreciate you joining us today. For those of you listening who are not Wild Health patients, please check them out at empowersleep.com. Is that right?
That's correct. Yeah.
Yeah, yeah, and I know they can pretty easy sign up process. I can personally attest to having just recently gone through this and learning a ton about my own sleep, making some modifications in my own life. And again, recognizing just through the education I got in my 1 hour consult at the end, about the importance of sleep in my own life and my patients' lives. If you are a Wild Health patient, make sure and ask your provider, and then tell me if they don't order you a test because we should be doing this. I firmly agree with that. We should be doing this for a lot of our patients as screening, prevention, not just diagnosis. And I agree with you. That's the way I hope this world shifts. So thank you so much, man. Any closing remarks?
No, thank you for having me. Um, Everyone who's listening, protect your sleep. And because when you do it for yourself, you start doing it for your family.
Yeah,
And for those of you guys who have kids, sleep is probably one of the strongest levers that you can pull for their intelligence over time.
yeah,
And, a child's brain is like a sponge. It's evolving and growing at a much faster pace. And if there's one thing you want to do for your children, is that you want to give them like a strong foundation of like sleeping well and building good sleep habits, because I don't have the evidence to say this. I don't have the evidence to say this with like 100% conviction, but my intuition is a child who sleeps better across like a 10 to 15 year time horizon will likely be in a better place from a mental health, from a physical health, from all of the health parameters as compared to someone who doesn't sleep as well. So I would encourage you all to take care of your sleep, take care of the sleep of your family, and it has like a compounded rate of return for you.
Yeah. Yeah. Well, treat your sleep like a powerful health asset is what we should all be doing. So, yeah, thanks again for joining us, man. It's been fantastic. We'll try and cycle you back. I know this is an exciting world. It seems we're seeing new things come out frequently about the risks and rewards alike of enhanced sleep. So, thanks for being on the show, Sahil. We'll get you back soon to update us some more.
Thank you, Jeff. You take care. Bye-bye.
You too, man.
Thanks so much for listening to the Wild Health Podcast. If you want more daily health education, be sure to follow us on Instagram, which is filled with health optimization how-tos, grocery shopping lists, guided breathwork posts, myth debunking, and so much more. You can find us at Wild Health MD on Instagram.